Our next topic, and people are coming up right now, is, let me get the right page here. Yeah. Our next topic is on making value-based contracting work for you. And we have Ed White, who is a partner in Nelson Mullins, who I work with quite closely. Kelly Conroy of Pinnacle Healthcare Consulting, who I've known for a very long time and also worked with quite a bit. And Robert Ball of Enlace Health, which is our sponsor. He's here from Atlanta, and he will tell you a little bit about his company as he goes on. And Juliette Price, because she's here and we need to use her.
Because she's here.
And the moderator is none other than Heather Miller, who I've been working with for 15 years or so. First abroad in Brazil and now at Nelson Mullins. Very good.
Hello, testing, great. Good afternoon, everyone. First of all, I really want to thank all of you that are here in attendance in person. We've had this forum for many years, and I really look forward to seeing each of you in person each year. Sometimes it's the only time I get to see you, so thank you for coming. And for those of you who could not attend in person, thank you for coming virtually. Mike introduced our panel members, and you have the brochures in front of you to see more insight into their credentials so that you could ask them questions when the panel is over. You know, our prior health law forums, which have been going on for many years, have always had a partial focus on ACOs because the payers have begun switching from that fee-for-service model to the value-based pay-for-performance type model. And as you know, there's now the new intermediary in the healthcare market, and that's the VBEs that we have been discussing this morning. And the one distinction, I shouldn't say the one distinction, there are many distinctions, but what we're seeing is that this is about the time to bring primary care back and the emergence of the pay-vider relationship. And I have to give Juliette credit for that, for coining that term. So the distinction is that pay-viders really in the VBE world is now we have these relationships between payers and providers that we didn't see in the same context in the ACO world. So a big theme in this panel is going to be those pay-vider relationships, climbing that Mount Everest, as Juliette said, and coming down that Mount Everest in the contracting world for VBEs to be successful, and also the shot clock, right? Mike Siegel has been talking about ACOs for over a decade, and we thought that there would be a huge mad rush to the ACO world, and there are a lot of players in that space. But what we're now seeing is that those that sat by the sidelines are losing a lot of their leverage in negotiating with ACOs in today's world. And so we need to focus on the fact that time is of the essence in this VBE world, and that hospitals and providers should not sit by the sidelines and wait like they did with the ACO world. So I'll just leave this here right in front of them, just as a reminder.
You may turn it over so it starts to.
I would, but Amazon sent it.
Okay. Okay. All right. We'll do it.
There we go. So to start the panel, you know, these four panelists eat, sleep, and breathe value-based care. And they have a plethora of information to share with you. And I'd like to start with Ed. So Ed, can you really go into some of the overviews on VBE? I know your next panel will have more of a focus on the regulatory side, but if you could give us an overview on VBEs, that would be wonderful.
Sure. And I actually, we've got a slide left over from the last presentation. I know Christine was going to hit this slide, but I just real quickly, Christine, you're a plug for you, but I think this concept in the payer negotiations, one strategy she's employed is you, particularly with hospitals, you take your most lucrative fee for service and convert those on a revenue neutral basis to risk-based contracting, start stepping in there. But Christine can talk more about that on a break because we're in the next panel, but I don't want to leave that behind completely. So basically what I want to just give a conceptual overview and let the rest of the panelists kind of weigh in on some different perspectives. We have gotten some new regulations for both the the Stark Law and the anti-kickback statute safe harbors. And it's a pretty significant shift in the regulatory environment. And these new rules are designed to encourage and facilitate the transition to value-based contracting, which is some form of risk-based contracting. The concept, and I like to use charts to sort of depict what we're talking about, but the value-based enterprise is in the center. And this is just a depiction of, say, a long-term view of where a provider may go with a technique like a value-based enterprise. These are Medicare-specific rules, but these concepts are, can overlap well with commercial, products and bundled payments, et cetera. And Robert's going to be talking about some of that. But the idea, and you're probably seeing this emerge in the marketplace, that there's an intermediate entity that is actually doing this contracting with providers and basically negotiating the downstream risks that providers bear in some form in their contracts, whether it's withhold or shared savings or some sort of capitated payment. And CMS has announced that by 2030, it wants 100% of its payments in some type of value-based payment program. And the Innovation Center is still working on things. We have the ACO REACH, we have Medicare Advantage. The direct contracting entity is phasing out this year and can transition to an ACO REACH. But looking at sort of the long game view, and this is just an example, like a health system forming a value-based enterprise. Now, this can be as simple as something in a contract between two parties. I think the long-term view is to create a separate entity with its own governing board to manage and do the value-based contracting. One of the things that Juliette spoke about was, the resources to providers to empower them. A lot of times providers alone aren't really going to hit the sweet spot on what they need to be doing. And so this can be a vehicle to do some of that from a lot of perspectives, whether it's Medicare program or it's commercial payers. The most significant thing about these new regulations is the first time CMS, which is a Stark agency, and the OIG, which enforces the kickback statute, they work together in tandem to try to build a set of rules and principles that could be used. And there's some differences, but they're very useful. The key distinctions is, a lawyer practicing in this area with the regulatory matters, I found these regulations to be very significant and a very substantial shift in the regulatory environment, because if you're in a value-based enterprise, and these boxes at the bottom, just imagine those as different groups or networks of aggregation of physicians that are contracting through participation agreements with this entity called a value-based enterprise. And if they meet all these requirements, there's no fair market value standard for the Stark Law. There's one nuance in the anti-kickback safe harbors. There's no prohibition on payments varying with the volume or value of referrals. And we'll talk more in the compliance session at the end, but the fair market value requirement and the prohibition on payments varying with the volume or value of referrals has been in a centerpiece of a lot of the large enforcement actions and judgments against providers for violating the standards, either under Stark or the anti-kickback statute. When you create a value-based enterprise, and again, this stuff can overlay with commercial, but when you create a value-based enterprise, you can have the participants required to restrict their referrals to other value-based participants. So there's an opportunity here. Here we've got the health system creating it. That could be anybody can create a value-based enterprise. It can be any type of facility. It can be a person. It can be an entrepreneur. But when you aggregate providers, you can make it a priority. Patient choice and medical necessity are the two exceptions from the requirement if they're going to participate in a value-based enterprise, that they have to refer within those networks of providers. And it makes sense because you're all going to be working on value-based objectives and value-based purposes. That's what this concept has in place. On the far right, I've got the payers. I think over time, you're going to see more evolution in Medicare payment systems through the Innovation Center. But the whole idea here, and this is sort of piggybacking what Juliette was saying, you want to start and you want to show you're able to contract and the providers can bear risk. But at the end of the day, you want to position yourself for maximum leverage with your negotiations with payers. You're bringing the most value. That, again, when we say value-based contracting, we're talking about improving quality, lowering costs. The objectives of a value-based enterprise, there's 4 that can be proper objectives to qualify. Those 2 are 2 of them. Another one is just care coordination, bringing providers together. And then the 4th one is allowing providers or preparing them to transition from fee-for-service to value-based contracting. So all you need is one of those purposes, and you can start aggregating providers, and you're in a different compliance world with Stark and kickback statute. Real quickly, I'm going to jump ahead a couple of slides. I'm going to come back to the other slide. But there's basically these rules, and this is a very simplified summary of these rules. But there's a set of Stark regulations, and there's a set of anti-kickback safe harbors. And I refer to them as 3 models. And this is the exact nomenclature, but the first model is care coordination. There's one under Stark, there's one under anti-kickback statute, safe harbors. And the nice thing about those rules is there's no risk required. So you can be sort of an elementary stage, wanting to aggregate providers and start working and creating the connectivity, whether it's electronic systems, the protocols, and customizing protocols. And there's no fair market value requirement under Stark. There's no volume or value prohibition. You can restrict referrals. The anti-kickback safe harbor and care coordination is a little more restrictive. It only allows for in-kind remuneration, but you can provide the resources to providers, the physicians, and do it disproportionately. And that's sort of a major shift in the mechanics of the regulatory analysis. As lawyers, we typically live in a world where everything has to be proportionate. The providers have to pay 15% of the cost, but it can be subsidized, whether it's a health system, an entrepreneur, or whoever. The partial risk model, you start moving into, and it's not as, I read something that physicians don't like the word risk. It tends to scare them away. But this is really not that hard stuff. I mean, you can get in trouble with risk if you don't get the right modeling, et cetera. But it's basically things like withholds, or you don't get certain payments if you don't meet certain outcome measures on quality, cost, et cetera. And the full risk model is you're basically on some sort of capitated payment. But the nice thing about it is the benefits, the changes in the regulatory landscape are the same whether you're in partial risk or full risk. And it doesn't have to be 100% in the partial risk model. I think the physicians have to be at risk for 10% of the comp. The value-based enterprise has to be at risk for 30% under one concept against a benchmark of total losses. And, if it's a episodic payment, then it's 20%. Here's a depiction I like to show people, sort of start them thinking about these concepts. If you're going to start and create a value-based enterprise, this is what I would refer to as sort of an evolutionary slide. And in the first column, again, I've got the facility at the top. That could be any provider. It could be a micro hospital. It could be a surgery center. It could be a surgery center company, et cetera. And create a value-based enterprise. And our recommendation is for the long game, create a separate LLC or entity with a governing board. You can pay people to serve on the board to help really provide the resources and the know-how for the provider networks. I've just got one group in the bottom here, but you start somewhere, you start small. And like the first chart, I had a lot of variations there, but you just incrementally add as you get better, you do more things and you pursue more things. I put in between the first and second columns concepts that health systems are familiar with today: care coordination programs, gain sharing, code management, clinical integration. All that can go into this value-based enterprise concept. It would fit very well. And when you start aggregating providers, one of the requirements of these value-based enterprise, you have to define your objectives. One of those 4 purposes, you have to define the activities you're going to be pursuing, and you have to measure and keep the data on the outcomes and whether or not you're making progress. But that also fits very nicely from an antitrust perspective, the clinical integration in terms of showing the providers and documenting the providers are clinically integrated, so it can overlap with that as well. The care coordination in column in step 2, that's that first sort of introductory model. And in there, I've got the facilities subsidizing the value-based enterprise. There's no payers involved yet. They're just aggregating. Here it's one group. It could be a multitude of groups or incrementally add, and they're subsidizing that. And I've got at the bottom, they're working on some sort of care protocols, and they're receiving compensation. You have to step out of these rules and go to another safe harbor if you want to stay in the anti-kickback safe harbor for cash compensation and a care coordination model. But it's still a beautiful concept because you're aggregating providers, you're bringing them in to tie them together to get ready to start doing the risk-based contracting. The third step, I've got a depiction of, it's now, we're calling it a risk-bearing organization. And I go back to this concept of this doesn't have to be restricted to Medicare. It can overlap, and there's payers out there in the bundle payment programs, they're having joint ventures do this contracting. But at the end of the day, it's to be able to leverage your value proposition with payers and incrementally add to it. And, the thing that I really like about it, you get in that third column where you're impartial risk, no risk. From the federal regulatory perspective, there's no fair market value standard. There's no prohibition on the volume of value referrals. You can also restrict referrals. So those facilities and those providers that become a part of this, and they all work towards these protocols, they become a captive audience, but then you're working on the same objectives, and you should be designing and building the same objectives. And the final thing I'll say, this really is designed to be the provider's own innovation center. I mean, there's nothing here that is mandated that you have to do. You've got to have those 4 purposes. You have to follow some mechanical steps every year. But beyond that, you get to create and evolve and experiment until you find things that work.
Thank you, Ed. So, it's important to understand this federal regulatory framework, but it's also important to understand it because, for example, in the state of Florida, we have state laws that somewhat mimic the federal laws. And because we now have this federal guidance, it allows us to do things outside the Medicare, Medicaid context with commercial payers and have protection under the law that we might not have had before. So Ed, thank you for that explanation. Kelly, we've been working together for many years, starting a long time ago, even before ACOs started, and then through the ACO model implementation. Can you give us some of your observations on how clients are moving forward now in creating VBEs?
Sure. Thank you, Heather. Thank you for having me. I think Juliette did such a great job this morning explaining a very large, nuanced topic in a very simplistic way. So thank you for that. Before I kind of give you some observations about what I'm seeing in the market today, I'd like to just back up for a second and just tell you a little bit about my history, just so you can kind of get an idea of my background. So I first got very interested in ACOs in 2011, and Dr. Presti, I was at your presentation. I guess the answer is yes, ACOs are still here. I still get that question to this day. Are they still going to be here? I think they will, or some version of them will be here. But I was fortunate enough to be part of starting at the first ACO in the country called Palm Beach ACO. And I see lots of people in this room that were part of that. Heather and Mike and Lanny and Derek and Kirk Priest was the first person to ever say ACO to me, and Cheryl and Cynthia. Oh, I'm okay. Can you hear me better? Thank you, Cynthia. So that was an independent, fully independent group of doctors who I think in their infinite wisdom decided to include specialists. So we had 100 primary and 100 specialists. I don't see that too much in ACOs nowadays. It's really just primary and a lot of partnerships. So that was a unique ACO, very independent, very physician run, very physician owned, and just how you would incentivize that group of people is extremely different than how you would incentivize a group of doctors that work for a hospital and perhaps are being paid on RVUs. So after Palm Beach ACO, I went and worked for a really nice company called Aledade. I think I was employee number 5 or 6, and I talked to them today, and they're up over 1,000. They're now in 39 states. And that's like a very big aggregator of primary care around the country. Their mission is to put the primary care as the quarterback of care, and they do a lot of very good work. I think today they told me they have received over $400 million in shared savings. So Alade's making a big impact. And then lastly, before I became a consultant, I decided to work for Holy Cross Hospital right down the street here, or actually right up the street there, just to understand if the ACO playbook that I've been working with independent practitioners and specialists, and then with aggregators and enablement companies, would the same playbook work in a hospital setting? And the answer is it really does. It's just a little bit more difficult, especially if the doctors are paid 100% on RVUs. Because that drives them to see more, get new patients, and it doesn't really help them take care of the people that are assigned to their panel. They may or may not know, and see them at least once a year to figure out what's going on with them and kind of get in front of any bad things. And then finally, I became a consultant at Pinnacle Healthcare Consulting out of Denver, Colorado. And we're a very large company that has very remote, a lot of our consultants are remote, and we do a lot of work in healthcare transactions, fair market value, which ties very nicely with my work. So the story for me is, as a consultant, after running these things for 10 years, I started in February of 2020 when COVID started. So I would call everybody and say, I'm doing value-based care consulting. And everybody would say, what does that mean? I should point to Juliette's PowerPoint. So it wasn't until I figured out to say, I do 3 things. One is I do contract negotiations for value-based care. I help start ACOs, and I help performance improvement. And the third thing that I found a huge market for is there's a ton of vendors out there that have a really great platform, whether it's an analytic platform or home health, remote monitoring, or something to do with cardiac, or something to do with sleep apnea. There's just a lot of people that want to help these ACOs, and they didn't really understand how to position themselves to present that to the ACO, because they know the ACO or the CIN or any value-based care entity or value-based care entity that Ed's talking about, they have other priorities. So that's kind of how I got to be a consultant. And I just, to answer Heather's question, and oh, Heather, I'm sorry if I've taken so much longer, but some of the observations that I'm seeing out there is how many pockets of the country do not have ACOs. Florida has a ton of ACOs. Like Juliette said, there's one on every corner in New York City. There's practically one on every corner here. We have about 60 of them in the state of Florida, and about 78% of them did have shared savings. So before I became a consultant, I thought, oh, everybody does ACOs. Not so much true. I found out all over the country, there's big pockets that are not in an ACO. And the reason I like to talk about ACOs, obviously I've been running them for 10 years, but I think somebody made the point that very prescriptive. So whatever you do for an ACO, the same would hold true for your MA plan, the same would hold true for direct to employer plan. At the end of the day, it is all population health. It is about trying to treat the patient better, have better outcomes, and smarter spending. So that's the first thing I noticed, is there's just so many places that do not have ACOs or ACO-like things. And I think an ACO could qualify as a VBE with some good legal counsel. And the government has noticed that too. Many of you probably noted that November 1st, the final rules were dropped for this, and the government has really made a lot of changes, especially for the rural areas. So in the rural areas, one of the things we're getting called about is one of the new changes is they're going to provide advanced investment models. And for those of you who've been around for a decade, those first ACOs that came out did get advanced money. So these advanced investment models will give up to $250,000 for a rural area of underserved population. And then they'll give you some PMPM money, per member per month money, for the first 2 years to help you kind of put your structure together, because they totally can see that it's not even, the people that are in underserved areas are not in ACOs. So the government is really making a lot of changes. I think another big observation I'm finding is at Holy Cross went into commercial shared savings contracts before they actually started a Medicare shared savings. Now, I see that the other way around more often than commercial, but they went into commercial. The commercial contracts are very much modeled after Medicare because it is so prescriptive. But to everybody's point, I think that has spoken today, the transparency is super important. And one big shift that I'm just now starting to notice, and I don't know if this is a COVID thing or not, but the commercial payers are now starting to not negotiate maybe like a value-based care contract. They're now starting to purchase the service of population health and access to a network. So before it was very, the contract terms of attribution, roster management, what happens after you term, all those things, the trend in the inflation. I don't know. I think Juliette might have made the point that if you don't know how they negotiate it, what your benchmark is and what you're supposed to beat, you're not going to beat it. So that has been very complicated in the commercial side. And I think as they move towards purchasing population health, then I think that's going to be less complicated. And they're really looking to do that so they have some predictive analytics on what their premiums should be. Some other things that I've noticed, and this will really tie back to Ed's point, is most of the ACOs that have been around for a decade or less than a decade, they've done those top 5 things. They know to do annual wellness visits and become aware of who's on my patient roster. Before ACOs, doctors didn't even know who was on their patient roster or who the government thought they were taking care of. They only took care of the people that showed up in their office. One of my favorite little quotes from one of my doctors was, and I know this is hearsay for all the lawyers in the room, was, all of my diabetics are taken care of. And I said, how do you know? And he said, because I see them. And I said, well, what about the ones you don't see that Medicare just told us, they think is assigned to you? And that was like a light bulb moment for that doctor to say, you're right, there is a population of people that consider me the PCP, but they only see me when they're sick. So that light bulb went off. We've had a decade to understand that. So that's the first thing everybody did. The second thing everybody did is they went looking for that emergency room avoidance, don't go to the hospital if you don't need to go to the hospital. And then they went to skilled nursing facilities, and then home health, and then they started to look at Part B. But after doing that for 5 or 10 years, some would say the squeeze of that orange has pretty much been squeezed. So now they're looking for new and innovative partnerships. What can we do next level? And this is where Ed's talking about these value-based care enterprises. They really allow you to innovate in any way you want. Anything that is good for the patient, good for the population, and is smarter spending, you can make these partnerships. So a couple that I've been seeing out there are PCPs are starting to be included or invited to be owners in ambulatory surgery centers. We haven't seen that before. We've normally seen ambulatory surgery centers partner with a specialist who do the surgeries there. Well, now they're starting to bring the PCP in as part of that continuum of care and make sure he stays in the plan of care. And he can also potentially receive some of the dividends from the surgery center, and then perhaps allow the ambulatory surgery center to receive some of the shared savings. An awful lot like the bundle payment program. So it's kind of nice that the VBE is now going to allow the primary care to be part of that. Starting to see some really great things around cancer care. It's something that people haven't wanted to talk about, but now that you can pull all the different players together, that's been really nice. Let's see. And then the ACOs that are already up and functioning, and especially if they didn't have arrangements with specialists, they're starting to be able to have arrangements with specialists and sit outside of these anti-kickback and STAR clause or have a safe harbor. And I'm especially starting to see things like nephrology come together and start their own network and go out and sell to the ACO. Let us help you take care of your end-stage renal disease patients. Let us help you take care of your CK4 and 5 patients. So I just think it's an exciting time for ACOs because they keep saying innovation, and we know that we got $1 billion 10 years ago from the Center for Medicare and Medicaid Innovation Center. But the innovation is starting now because the FTC, the OIG, and CMS came together and made these new rules that Ed's going to tell you more about later. And now we can really see some innovation. I hope that wasn't too long.
Thank you, Kelly. Robert, you really have a unique skill set from your prior experience, whether it's legal, the technology side, being involved in healthcare operations. You're really seeing it from all different perspectives. And I'm wondering if you could shed some light on some of, whether it's the key topics or provisions that you're seeing as vital to the contracting process, whether it's between a VBE and a provider or the VBE and the payer, which are important for everyone to know about to ensure success in their VBE.
Absolutely, and thanks for having me here. And just by way of a little bit of background with Enlace Health, we have a platform, and this really starts to answer your question, and that is around an adjudication claims platform for bundle payments and for value-based payments, coupled with the ability to do the analysis and design episodes, design bundles, price them, and we do work with payers, work with providers, and really, so a lot of what Kristen touched on in that bundle payment world is where we've really focused heavily. Mike Siegel said something about wanting Juliette hour number 2. I'll kind of start off by that because I was listening to you and taking notes. So really, I want to echo some of what you said as a starting point. And one of the things you said is that, the contract, it's not an end, it's an element, but it's not the end thing. And I can't hammer home that more than anything. It really has to be what we've seen is we have the ability to do the analysis, to give the smarts as to what, how do you look at an opportunity, how do you define an episode of care, how do you price it, and then how do you go translate that into contract parameters and negotiate a contract, and then to be able to administer it, and just to see what we have about 120 million lives that are under contract primarily through large payers, but working with those payers to get them to understand that it's kind of the flip side of what you were talking about, the pain points of the providers. And so literally seeing those come together and then trying to put these groups together is not a trivial exercise at all. But it's got to be a program that you look at. Because what'll knock this down are some of the smaller things. So the contract is certainly a big element of it, and as lawyers, that's where we spend a lot of our time trying to go through that and make sure that the contract elements and the definitions do really reflect. And I'm a big fan of using a term sheet and really getting the business people together and understanding exactly what are the goals, what are the success of this program. Let's work backwards from there. What are the outcomes you're looking for? Versus sort of sometimes the traditional contracting, and you were talking about providers. I know payers are like, here's the paper, sign it, so having to get them through the idea that, there's actually a program here that's got to be a win-win. And that whole concept of collaboration and the collaborative process of negotiating is just, it's foreign to a lot of people in the industry. If you look at my resume on here, you'll notice I have not spent 25 years in healthcare. I've been in and out of it from time to time. But one of the values that my CEO said when he hired me was, you can actually sit down and when somebody says, well, this is the way we do it in healthcare, you go, why? So let's change it. So we're going to try and change some things in healthcare. I get to be the one that goes, why does it have to be that way? So anyway, that's but I think that's the key. Another thing I see, and again, I'm coming back to a point, is this data. I've been with payers who literally will put down and say, we want to do a full prospective risk model with the provider. You're going to pay all the downstream providers, and here's the price we're going to pay you for a knee replacement bundle. And sophisticated providers, not somebody in rural America, but sophisticated multi-office, big providers go, well, how do I contract with a facility? What are the right rates for this market or for this procedure? And just try and get them to share that data. Got one anecdote of a administrative officer of a large provider group that said, I go out and start asking some of my patients for their EOBs so I can get an understanding of what some of the allowed claims are in my areas. Because again, a lot of the savings that those payers are looking for, especially in things like orthopedics and the bigger provider practices, are heavily on the site of service shift. If they can get it from inpatient to outpatient, and even more so outpatient to ASC, then that's where the savings can be. And if they play well together, there's a lot of savings for the payer, a lot of savings for the provider, or more money to be made by the provider, especially to the extent they're willing to take on some risk. But again, it's contingent upon the two of them working in a collaborative fashion, sharing data, and coming to something in an arrangement that's not it's not kind of what you were talking about here. Take this. They have to think long-term, and maybe they start off with something smaller. And then I think the other piece that, and also it can't just be a race to the bottom. It can't be, all right, if we squeeze all this out by moving everybody to an ASC, at some point that gets to it's a long way down the road, but at some point that starts to fade out. So I think the other thing that we see is all the quality metrics and the fact that you really are shifting to put these providers in a situation where they can focus on the right type of care from a cost and a quality perspective. If they have to take the risk in a post-surgery period for a readmit or a revision, then they're going to make sure that doesn't happen as much. And if they're paying for an ER visit, then that's good. Whereas under a fee-for-service world, they get to write, they get to check another box, get paid again. I was actually talking to a friend of mine who does hips, and he goes, if I have to do a revision on a hip, I get paid for that too. So that's kind of, that's interesting aspects of what we're looking at here that I think are awesome in this area. And then I think two other things. One is what we see, and this is inherent in what we're trying to do with having the claims adjudication and the claims administration platform as well. And I've seen this in other technology settings. I was in cybersecurity for 6 years, and I saw this writ large is you have these wonderful ideas and these wonderful initiatives and these great waves of innovation, and suddenly they crash on the beach of workflow. So again, big sophisticated provider organization that suddenly is saddled with all the downstream payments. And you say, well, how are you going to do that? And they go, well, we've got some Excel spreadsheets. We're going to handwrite some checks, and we're going to pay everybody from there. And you're like, well, because again, now basically in a lot of these bundle programs, especially with risk and with the downstream side, is you've now flipped a provider into being a payer. So they're now the payer for everything downstream. Before they would cash the check, okay, I get $2,500 for my knee replacement, deposit that check, distribute it. Maybe there's a little shared saving bonus along the way if I'm doing a retrospective deal. But suddenly now my provider group has to understand how to do claims administration and appeals process and adjudication and everything. So now they're a payer. So I think that's another piece that we see trying to really offer the whole soup to nuts around it. And then last but not least is trying to work with and enable these providers to have programs that they can now go to the payers with, because as you've heard from other speakers up here talking, I ran out of time.
No, keep talking.
But
You're
you've
good.
heard from other
got
people
plenty of
talking
time.
up here. The bundles, not every bundle looks the same. I think Kristen was talking about how some of these bundles can be customized, and so suddenly a provider, if they have to do, they've got 5 large payers and 6 direct, to employer health plans, then they're trying to figure out when they go to do it. They go, all right, whose bundle are we working on today? I'm operating on Juliette's knee. Is she under this one or she under them? And so am I a 30-day, 90-day? Am I, what am I doing? So those are just some of the challenges we see. And again, as lawyers, we have to pull all that in and think holistically and think beyond just the T's and C's of a contract, but to be able to pull all that in and then embody it in a contract is ultimately that's where it's gonna come together.
So Robert, you talked about, that crash, right? And, we're hearing a lot about data and transparency and a meeting of the minds. And we're hearing about the obstacles of the provider becoming the payer and then the pain points of the payer. What are some things that you think are really important to highlight from the beginning and kind of get out on the table from day one to avoid these obstacles down the road?
Well, again, it's a challenge. I think it is, the comments about crawl, walk, run is, it's part of our marketing message, but it's true. We try and do it is kind of, you're going to get providers and payers somewhere on this journey, and you don't know where they are on the journey. So you got to figure out how to get people on ramps that don't require them to jump all the way in. And that's tricky sometimes because, Kristen, you were talking about some of the economics of being in a bundle. Well, sometimes if you look at the unit economics of a particular bundle, sometimes I'll come back and go, well, back to your comment, the juice is not worth the squeeze there. So I'm going to make an extra $400 on this. Yeah, I'm making 400 grand this year. So then you have to start talking about, total addressable market economics and say, but if you do 1,800, episodes and you can shift 50% of those over here, now you're really starting to move the needle. And if you want to take on more risk, if you want to look at it as a total cost of care, not just for that episode or that bundle. But again, I think you have to look at this, and I think Juliette, you had touched on this, this is a long-term transition from the way you've done business before to the way you're going to do business in the future. So you need to get on board, and then we as advisors, consultants, providers, lawyers need to help bring people through that, because I think the juice is worth the squeeze in the end.
So given that this is really like a lengthy and complex transition, right? And Juliette highlighted in her keynote speech about timing being of the essence for negotiating contracts with payers, right? So they want to say start on January 1. If you're giving advice to providers today, and we are already in November, right? January is around the corner. So we know that that's, highly unlikely. Juliette, would you set forth what, maybe give the audience here sort of a timeline on if they're thinking about setting up a VBE, when they really need to start taking their first, second, or third steps?
Yeah, I think I would completely agree with, part of it is just getting started. You don't know what you don't know until you just start. That being said, that's why you don't want to go full risk on day one. Like, it would be insane to go from I have no experience taking risk to I'm going to take a full upside downside arrangement. I mean, that's just like crazy. Please do not do that. You will lose your shirt. You really will. And sometimes there are, venture-backed entities who they're fine with that. They have extra money, they can burn it, they can lose their shirt and learn along the way. That's not true for most, especially provider-led organizations. So you also have to know who you are, right? If you've just raised $1 billion and no one cares if you just burn it, go for it. But most people don't have that money to spend. So I think, and this echoes something that Kelly was saying, is use the various programs available to you to start exercising those muscles, right? So MSSP and Medicare has very generous, and as of Monday or Tuesday or whenever that was, even more generous, like, hey, come hang out with us. We're going to give you some free money. And there's very little risk. You can go into that program and really just start to learn what it is like. You don't need to pay downstream providers. You don't need to do this. You don't need to do that. So if I were someone thinking about making the leap, I would look at all of the available programs to me, both from the feds, from my own state, from my commercial payers. Some commercial payers are out there offering, I know in the market that I work in, they're offering essentially MSSP, right? But it's on the commercial side. So they're sort of like, hey, just come hang out. We'll pay you a PM just to meet, just to kind of be in this space with us and learn together. And then as time goes on, they want you to take on more risk. So what I would do if I were you is I would look at all my opportunities and just line them up and say, okay, DCE or ACO REACH is risky. That's the highest risk, right? Taking total cap for total cost of care is as risky as you go. And what are all my opportunities before that? And how do I start experiencing one and then another and layering on these capacities that you have to build? You don't need a TPA on day one, but as you go along, you're going to need the ability to do some of that, those capacities. This, I want to just like really nail something that Ed said, and I don't think, and I'll just say it louder, getting the infrastructure of your VBE right is so important. I'm going to say that one more time. Getting the legal structure of your VBE right is so important. Please do not do it without the advice and counsel of people who have done this before, because I am here to tell you that there are a lot of entities that didn't get expert advice, and later on they are regretting the way that they legally set themselves up. So just really, I was not paid to be here. I'm just saying you have to get advice, not just legal, but otherwise from folks who have seen what goes wrong when your VBE is not correctly set up. And by not correctly set up, I just mean, as an example, do you create equity partners early on where you may not understand the full amount of equity that you're actually giving up over time, right? You may take on a partner, not understanding just how much that's going to cost you in the long term. So I will underscore that until the day I die. I think the other thing that just sort of sitting here and listening to everybody's comments, I think there's something that we're all talking about, but we're sort of not naming, which is power. VBC also is just a fundamental shift in power. And I think sometimes it's helpful to just take a step back and name that. And as you do your work and moving of it, like start thinking about like who holds the power now, as we were saying, right? Insurance companies are used to, no joke. I have provider clients who today is what, November, whatever. They still don't have a signed contract for 2022. That is how fee for service has dealt with providers and provider groups. And all of a sudden, we're in a relationship where providers and provider groups can become payviders and eat the insurance company's money's lunch. Like, we have to acknowledge this is a massive change in power. And so there is going to be resistance, right? Everybody knows this lesson. If someone holds power and someone else is taking it away, right? Like, we fight wars over that, right? So be ready for that. But also you have to acknowledge that is a fundamental shift that's happening. And I think another place that we have to acknowledge this is happening is in a fee-for-service system. Primary care physicians are on the bottom of the food chain, absolute bottom. In a value-based world, they're on top, at least close to the top. And so what does that mean? Are primary care physicians ready? And by physician, I mean physician groups, aggregators, all these kinds of things. Are they ready? If not, why not? What do they need? And also, if you don't have primary care physicians that can drive attribution, what is your strategy in a value-based world? And the prime example for that I always give are hospitals. If you look at value-based payment, if you think about, and I think you did a great job sort of like summarizing, like where have ACOs gone, right? If you're looking to find shared savings, where do you find shared savings? Avoidable inpatient, right? So now I'm operating Fort Lauderdale Medical Center, whatever, and there are now 60 ACOs eating my lunch. Yes, a certain number of patients, I always say, will get hit by a bus on any given day, but that's not what drives revenue to hospitals, right? So if all of a sudden there are all these ACOs in my little area taking those inpatients' stays out of my hands, I'm seeing significant revenue decline. And if I'm a hospital that has only employed physicians and specialists, and I don't have a broad PCP network that's funneling attribution, that's who's losing. So it's an important point to make. I think we should name it. I would say that hospitals have been very late to the VBP table, to their own perhaps demise. I'm not, don't quote me on that one, but it's coming. I know. I saw that. I was like,
And that's precisely why I have that timer
oh
there.
God.
So Juliette, thank you for highlighting the importance of the legal documents, and not because I'm a lawyer,
Yeah.
but I've been involved in deals where when the VBE regs first came out, I would have these intermediary parties, I'll call them private equity,
Yeah.
setting up, right? They're setting up joint ventures and surgery centers, and they have employer-based contracts, and they want to pay their doctors a certain amount of money. And no one's getting fair market value appraisal. So when you say, are you a VBE? And they say, oh yeah, we are. People just throw it out like it doesn't really have meaning. There's no legal construct. There's no particular documentation that needs to be in place. So my advice for everyone that's listening is, if somebody says they are a value-based enterprise, ask for the documentation that supports it. Okay. So now that we got that out of the way, talking about hospitals, right? And the importance of having a tight primary care network for attribution purposes, right? That shows also a lot of the shift from, specialists really being at the top of the food chain, primary care being at the bottom, and we sort of see this shifting. but also what's happening is the specialists are starting to be disincentivized to be innovative on these types of value-based enterprises and relationships because they think they might now end up with the short end of the stick. So for anyone on the panel, is there any advice that you could give with respect to specialists and their roles in these VBEs?
I could take a stab at it, Heather. I kind of been through a different lens than that since Palm Beach ACO started with specialists. They were very incentivized and still are. I'm starting to see specialists all over the country come together. Like nephrology is a very big one. Nephrology are coming together to create a bigger. In the olden days, they used to come together to be a large group to negotiate higher fee-for-service contracts because of their massive volume. Now they're coming together and they're coming to the plans with what I would call a transcript of excellence. Lanny, you probably remember that name, right? So if you're a specialist and you hear what's going on around you, start to figure out what are those key performance indicators that I can start tracking for nephrology, for cardiology, for ortho, for any of those major specialists, and start tracking those. And you can actually go to the plan and say, here's how I can help. Even if the ACO doesn't want your help, the plan will want your help. So if you can put together with some help from a consultant or just model it after somebody else that's been successful, there's a lot of room for specialists to help. Again, Heather, to your point, primary care is what has driven these programs to come together, but it's going to be the specialists that keep them together. We can't do this without the specialists. We can't do this without the hospitals. We've tried for the last decade and it's gone pretty well. I think we've saved something like $2 billion, but it's not going to be sustainable if we don't bring all the stakeholders together. So I do think there is a lot of work being done under value-based care for specialists out there.
Well, that's our area of focus, is working with specialty practices. And I will tell you that the larger provider organizations that are growing, and some of them, as you said, are PE backed. So they certainly have a hot poker prodding them. I'm trying to be nice here to make more money, but they're competitive too, and they definitely want to grow. And so I think it goes back to what Juliette said about power. The flip side is control. So one of the ways a large provider group can get more power beyond just getting more payers to sign up and be part of the network is to take on some of this risk in one fashion or another. And the bigger ones have growingly the sophistication and the financial wherewithal and to be on the cutting edge of this and be some of the leading edge. And some of the ones that we know are anxious to do that because they see the opportunity, because they want control. And frankly, again, we're in the commercial space. They want steerage. They want business coming to them. And then if they then are the risk-bearing entity and they're controlling downstream where that money's going, now they have the power over the facility and the anesthesia group, and they can start to exercise some more control and make a little more money and have, and so I think that there's, and then last but not least, we hear a lot with, and again, as everybody in this room knows 10 times more than has forgotten more this week than I know, 10 over, but a lot of the primary care value-based contracting hits a wall when it gets to specialty care. So what do you do? So, and we know a lot of the big primary care groups that are in VBC, when they get specialty care, suddenly it flips right back to fee for service because they don't know how to. They may be getting a PMPM, but when it gets to that, they're like, time out, I got to go back here because I don't know how to handle that. So I think if the specialists can get in there and, folks like us can help them get in there, then you can start to couple that with some of the big groups to do, okay, I'm doing the primary care and I can also handle your population if it gets to the specialty side.
I think we've also seen, I couldn't agree more. And I think we've seen some movement towards, specialty care becoming, not physically, but sort of either telemedicine or otherwise like co-located with primary care, right? And especially for folks who serve under underserved, beneficiary members, however you want to call them, they know, primary care physicians know, I'm looking at something on your skin. And I don't know what it is because I'm not a dermatologist. But if I tell this individual to go see a dermatologist, it will not happen. It just won't happen for various reasons: cost, convenience, their crazy busy lives. And so how do you establish these new partnerships with specialists, right? A teleconsult where some imaging sharing, like all of these new things are starting to happen where it's not sort of like traditional what we think of co-location, but it's some form of communication and collaboration in new ways. And I think the other thing that you're pointing out is, you know, the market, right? We always talk about TAMs and SAMs and SOMs and all this nonsense, right? We look at total cost of care arrangements typically from the group of people, and this is exactly your point about the diabetics, right? You have been serving the population who has traditionally come to you. Once you enter into value-based arrangements, you have more time for the folks who weren't coming to you, who, by the way, are probably a little bit more complex and underserved. So you can start steering that business, right? There are probably a lot of people, you've always been seeing people, some percentage, let's just call it 10, need a cardiologist. Okay, that's been the traditional model. But once you start doing more work with those folks that haven't been coming in, who are not coming in for very valid reasons, and now you're doing home visits, you're meeting them at a public library, you're doing whatever it is, you're doing televisits, you're starting to realize this person thinks they're just growing older. No, they have a cardiac issue. They need to see a cardiologist. So your TAM actually increases. It's not a race to the bottom. And I couldn't agree more. And I think we should be saying that until we're blue in the face. This should not be about a race to the bottom. This should be a race to the top of the care that everybody gets. And the way that's going to happen is it's going to look very different. I think also rural places are going to look, it's going to look a little different, urban, so it's not going to be one size fit all, but absolutely it should not be a race to the bottom.
This is a question I have to anybody that wants to answer it, right? You know, Juliette, you talked about in your opening the air conditioner example. You talk about meeting someone at the library, right? And all of it is about, you know, health equity, meeting patients where they're at to try and get them the care that they need. But that's not something that you write on a claim form. So in your negotiations with payers, can someone shed some insight on where in that contract negotiation process it is best to address those extra costs that cannot be put on a claim form?
So I'd love to give an example, but then hand it off here. I think the most powerful example of how value-based payment changes physician behavior was the COVID-19 pandemic. And I'll give you two specific examples. On behalf of an ACO that is a client entering ACO REACH, they were trying to do physician reach out a few years ago for DCE. They weren't successful. They went back to the same physicians this year and got yeses. And the reason they got yeses were this is independent small practice physicians. So they all own their own practices. So what the practice makes is what they take home for their family and maybe the nurse practitioner who they hire. The reason these docs said yes this time around is they said, we have almost no value-based contracts, but we have a tiny bit, 5%. That money, those capitations paid for my nurse. I didn't have to lay off my nurse. So I wasn't in this before because I couldn't wrap my head around it. But the second all of my patients did the right thing, which was to stay home, I didn't have to fire my nurse, who's, by the way, been my nurse for 30 years. They got it. That clicked in for them. I have a large provider. They're the largest provider-led IPA in New York City. They are in very risky arrangements, what we call level 3, total upside downside. They're a large group of providers and they serve some of the most underprivileged people who live in New York City. And the day the pandemic hit, which is all you know, New York City was hit very hard and very early. They closed all their clinics and immediately became the largest testing and then immunization site for New York City. They single-handedly helped the South Bronx through the COVID-19 pandemic. They lost their own doctors along the way before the vaccine was available, but they were able to do that and do that without spending 1 minute thinking about their compensation structure because they are in advanced value-based payment arrangements. And I, to this day, am not quite sure what would have happened in the South Bronx if that group of doctors weren't there in those financial arrangements.
I think, Heather, one other place to where, that's a great point, is COVID changed everything. Now everybody understands value-based care really well. But just to answer, when should you start to talk about that in your contract negotiations? I think the most impactful place is if you're at full risk. If you're at full risk and they give you X amount of dollars per capita per patient to take care of, depending on how your program is, you could decide to use that money to put the air conditions in, to provide transportation, to do Meals on Wheels. There was a gentleman here that I think just left, but he has a PACE program. PACE people understand it perfectly. They get X amount of dollars to take care of everything, and whatever's left over, they get to keep. But people really become really smart about how to spend that money. How do I keep that patient out of the hospital? So I think those risk contracts are the place to negotiate and be able to do that stuff. Secondarily to that, the plans will give you some money for that. They do realize it. And I think Medicare is just about to open up a big can of worms with health equity and tracking. They call them the social determinants of health. I call them the social influencers of health. So let's figure out how can we influence that patient to eat better in that food desert. So I think Medicare is about to open the door specifically by giving people about $250,000 to start this, and then giving them PMPM just to keep them going. So I think we'll see some new innovation and some more money being put into this area.
And I'll add just a couple points on there. And I read an interesting article recently that talked about when you reduce unnecessary care and you have, the volume of maybe procedures or admissions or whatever going down, that doesn't necessarily correlate with the cost infrastructure needed to provide the services as a whole. And that may include, when you start talking about health equity, because you're going to be doing things that are sort of outside of typical clinical evidence-based medicine, the social determinant stuff. And so this article suggested, and this was going back to, I know Juliette, when you talk about negotiating with payers, you got to, bring your proposition of, your data. And part of that may be, what are your real true costs? So don't wait until necessarily risk-based, but you start those negotiations as you approach payers. But not only that, under this value-based enterprise concept, you can disproportionately, if you have a hospital system or a private equity group, whomever. And I read somewhere, I know we're going to talk about health equity in a later panel too, but I read somewhere, 50% or more of somebody's health is determined by social determinants. And that's sort of the other side of the coin. And then we all talk about evidence-based protocols and clinical stuff. And so if you really want to break the spin, you got to reach out and be doing these other things. And you had a great example of buying air conditioners, doing a study, a system. But that can be disproportionately subsidized in a value-based enterprise. If you got a capital partner, a health system, and you want to start breaking that curve, you want to start showing the payers what it costs, and you want to start showing the outcomes, not necessarily wait, but make that part of your innovation and creation and innovation with these new.
I was, not to steal the thunder of the health equity panel, but I was at a conference about 6 weeks ago, and the health equity panel was talking about that they asked, there was a group from Detroit and there was a group from New York City, and they were asking, what's the biggest thing that's holding back health equity? And both of them started out by saying fee for service. And so,
No way. Correct.
yeah, they were like, one of the biggest hindrances to health equity is fee for service. So
Yeah, there was a recent article in Politico about remote patient monitoring, and basically this health system, and I forget where they were, and I got called to comment on it. And so the long story short was like, this health system has decided that remote patient monitoring is very helpful. They did a study, they did a pilot, la la la. They went to their Medicaid department. Medicaid said, we won't pay for it. So this journalist calls me and they're like, well, what's your take on that? I said, my take on that is stop asking for Medicaid to cover things. Get into fee for service and do what's right, right? I'm not wearing mine today, but this is remote patient monitoring, right? Like I have elders in my life whose lives have been saved by that, right? They think it's just a weird, well, it's saying I'm in a rhythm. Well, I might as well just go see my doctor. They were having a major health event. We do this for ourselves and our loved ones, but we don't bring it to scale because we're so busy trying to get a HCPCS code approved. Just get into value-based payment. Take the money, do what's right for your patients.
All right, we have about 4 minutes left to the panel. Does anybody have any questions? No questions? Tom?
So talk a little bit about top food chain, bottom food chain you're going to convert, or primary care are now at the top. Are the specialists ready to be at the bottom or middle level to food chain, my experience is nobody will accept making less money, right? Equity, if that's the case, certain people are gonna make more than others.
You know, we're all out of time on this panel, so we gotta go. Well, in 4 minutes, I joke, but I only joke because I think it's the thing we're not naming. I really think it's the thing we're not naming right now. And look, I have no disdain for hospitals or hospital systems. I don't. What I see though is that they have buried some, not all, let's say that, buried their head in the sand and just said, no, we're good. We just want to be the region's best, double, triple, blah, 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 bypass. That is not what the majority of the patients need. And we've done work all around the world, including more recently in Saudi Arabia. They don't have an insurance system, right? So they were like, hey, help us do one. And of course, the first thought is, well, we just should replicate what the United States is doing. My first question was, what do you think the United States is doing? They say, oh, that Mayo Clinic. And that's when I said, yes, the United States is the best place in the world if you have the most complicated 1 in 10 million case. But if you have type 2 diabetes, good luck to you in the United States, right? That's the truth of what we've built, right? And we should not knock what centers of excellence like Mayo and others are doing, but we have to come to grips with the problem that the biggest cost drivers in our delivery system are not the edge cases. They are the everyday hypertension, diabetes, obesity, the list goes on, but it stops at about 10 things. And that's what the majority of the population has. And we simply just don't need specialists for that. We need better primary care that is integrated with specialty care. But that thing that you're naming, it is not talked about enough. So I guess my long story short would be like, no, we're not ready. We're not ready. We're not ready at all. And just like I mentioned earlier, historically, for the past however long the earth has been here, we fight wars over power. So keep your eyeballs out because it's already happening and it will get messier and messier as this transition continues.
And I think we can put a name to it. I'm calling it the war of attribution.
Oh, wow. That's amazing.
On that note, Julie.
On that note, we'll conclude the panel on the war of attribution.